Yep. So this is a very broad topic. Obviously, a lot to cover in 20 minutes, but we'll do our best. I've done this purely question-based as a chance to launch into further discussion or thoughts that you might have. So with that.
30 minutes, you know, that you're 30.
Oh.
What 20 minutes were there? Here's 30.
Oh, all right. Well, we'll drag it out. No, I'm kidding. All right. So some key references that I recertified 6 years ago. And the key references really are, as it pertains to this talk, the most recent guidelines for coronary artery revascularization were updated in 2021, published in 2022. And the Mayo Clinic Interventional Board Review is a great resource. Everybody knows about that. And also the ACSAB, the CATSAB is also very, very good. So if you focus on those three references and really dive into them, you're going to be fine on the boards. I'm not worried. So just to kind of set the stage, the 2021 guidelines for revascularization, this was a pretty seismic change for us. And I think the two hallmark things that I would take away from it, number one, it told us that shorter duration DAPT after PCI in patients with stable disease is reasonable. And the goal there is to reduce the risk of bleeding. And then after consideration of ischemic risk and bleeding risk, selecting a transition to a P2Y12 inhibitor monotherapy, meaning stopping aspirin after 1 to 3 months, is now in vogue and supported by randomized clinical trials. So this is really supported in this graph that you see. On the left, the large green is your stable ischemic disease that receives a DES. You know, we're going to go now to 6 months DAPT. If you need to, you can discontinue aspirin after 1 month. And if you need to now, a 2B indication to discontinue DAPT completely after 3 months with the newer generation stents that we have. So really shortening the DAPT duration is key. Bare metal stents we don't put in here. They're not available. Regarding ACS patients, we're still looking for 1 year of DAPT ideally. But we can even shorten that now to 6 months for our higher bleeding risk, and even shorten the continuation or discontinue aspirin after even 1 week. Or 1 month, I'm sorry. So that's pretty impressive stuff to take home from those guidelines. There's obviously other things in there, but as it pertains to antiplatelet therapy. So to dive into questions here, so number one, so the questions on the boards really focus with regards to antiplatelet therapy. There's a pharmacologic or pharmacology base that you know the answer, you don't. If you don't know it, move on. And then there's clinical vignettes, and that's kind of what I've done here. So number one, which of the following antiplatelet agents interact directly with platelet surface membrane receptors? And I don't want to wait. You don't have things. So just, if you know it, yell it out. If not, I'll move on. Clopidogrel, Prasugrel, aspirin, Vorapaxar, both A and B, A, B, and D. So A, B, and D, okay, directly, that's the key. They act on receptors. So this is a diagram that kind of summarizes some of the antiplatelets that we have to date. So the P2Y12 receptor antagonists are on the right. You guys know these: Clopidogrel, Prasugrel, Ticagrelor, Cangrelor. Elinagrel was an IV formulation that actually stopped in production in 2012, but was a precursor to Cangrelor. The 2B3A inhibitors act through the surface receptor. Eptifibatide and tyrofenibran, you know, these are really out of vogue now. We're not really using 2B3A inhibitors. In fact, ipsiximab is no longer available as of 2020. It's off the market. Vorapaxar, this is a PAR1 antagonist that helps or activates through the thrombin receptor on the platelet surface membrane. There's some evidence in patients post-bypass and even as secondary prevention with PAD, but it's an add-on therapy to DAPT. So obviously, as you know how that goes, higher bleeding risk. So it's not really in favor either. But the one that does not is aspirin. This works through the cyclooxygenase enzyme, which is not a surface cell receptor. All right, number two, which of the following is not a major criterion for the Academic Research Consortium? High bleeding risk. or ARC-HBR. Active cancer within 12 months, moderate to severe platelet thrombocytopenia less than 50, ischemic stroke within 6 months, or hemoglobin less than 11. So not a major criteria. So B. So platelet count less than 50 is not. So again, this is the major and minor criteria of BARC 3 or 5. So just to review, BARC 3 is a bleed greater than 3 to 5 milligrams per deciliter of hemoglobin. BARC 5 is a fatal bleed. You have major and minor criteria of each. The major ones I've highlighted, they're in this question. Hemoglobin less than 11 is 1. Active malignancy within 12 months is 1. And a moderate severe ischemic stroke within 6 months is 1. So any of those is going to be a major risk factor. But the platelet count of less than 100, not 50. So just look at your questions very closely. Question 3, all the following are true regarding Ticagrelor. Ticagrelor inhibits cellular uptake of adenosine via the sodium-dependent ENT1. I'm sorry, all the following are true except. Number B, Ticagrelor is metabolized to adenosine. C, it significantly increases coronary blood flow. D, it inhibits platelet activation via the adenosine 2A receptor and 2B receptor, whose genes are upregulated with ischemic injury. And E, there's an increase in serum creatinine with Ticagrelor comparable, or that's compared to clopidogrel in patients in the PLATO trial. Or F, all the above. Someone said D. So all the true except. So you have to think carefully. Is Ticagrelor metabolized to adenosine? No, it's not. And this is the mechanism you have to know. So just taking a step back, so why is Ticagrelor so important? Well, we know that the PLATO trial showed a cardiovascular mortality benefit. Why is that? Well, the thought, some schools of thought is that it has a vasodilatory and vasomodulatory capacity to it. So when you compare Ticagrelor to adenosine, they're very similar. Ticagrelor increases coronary flow, so does adenosine. Ticagrelor decreases MACE, adenosine decreases ischemic reperfusion injury. Adenosine increases platelet inhibition, so does adenosine. And Ticagrelor has been shown to increase the creatinine levels in patients with ACS, and adenosine decreases the GFR. So very, very similar. And Ticagrelor has the 10 to 14% incidence of dyspnea, and that's also associated with adenosine. So the thought is that really the benefit of Ticagrelor is that effect of adenosine. And how does it occur? Well, Ticagrelor inhibits the reuptake of adenosine that occurs through the metabolism of ATP through hypoxia. So by Ticagrelor bonding to the ENT receptor, you reduce the uptake, so that you just have more of it, not that it's metabolized. So important description. Okay, number 4, which of the following mechanisms leads to inhibition of platelet function following treatment with P2Y12 receptor inhibitors such as clopidogrel? So here you're looking at the mechanism, right? Usually when they ask mechanistic questions, they can be pretty random, but there's some meaning behind it. So clopidogrel binding to the P2Y12 receptor causes reduction in cyclic AMP, increase phosphorylation status of the vasodilator stimulated phosphoprotein, inhibition of phospholipase C, inhibition of adenylate cyclase, or inhibition of protein kinase C. Tough question. So it's a couple-step question. So basically, it increases the phosphorylation of VASP. That's what Ticagrelor or clopidogrel does. So when clopidogrel binds to the P2Y12 receptor, it induces an increase in adenylate cyclase, so cyclic AMP. And when cyclic AMP is elevated in the intracellular level, it promotes the phosphorylation of VASP, this protein right here. And when that's phosphorylated, it blocks the platelet activation. That's important to know because one of the assays that we used to use, not anymore, to assess platelet activity or platelet aggregation was the VASP assay. So you're actually measuring this phosphorylation activity. But that's really gone out of vogue as well. But it's kind of important to understand the mechanism. Okay, number 5, which of the following best describes the reason Prasugrel provides more potent and consistent platelet aggregation inhibition compared with clopidogrel? It's absorbed over broader gastric pH and is therefore less affected by PPIs. The active metabolites formed by a single oxidative step. The effect of foods such as grapefruit juice is lesser on Prasugrel, or D, all the above. So this is the main reason why Prasugrel is more effective, okay? So when you look at Prasugrel versus clopidogrel, Prasugrel has a more prolonged antiplatelet effect. It has more consistent antiplatelet activity, but it only undergoes one oxidation step in the liver. And in doing so, for every 100 molecules of Prasugrel you have 60 active metabolite. Versus clopidogrel, for every 100 molecules of clopidogrel, 85 of those molecules are going to go through further oxidation. And so you're left with only 15% of active metabolite. So it's a two-step oxidative process for clopidogrel versus a one-step with Prasugrel. So it's much more effective. This was the TIMI-38 trial. You guys all know this probably by heart. It's an older trial, but it's a landmark. It showed that it reduced the risk of major primary endpoint, cardiovascular death, MI, and stroke, but it did come with a cost, and the cost was higher bleeding. And that's an important aspect to know. Okay, number 6. Which of the following statements regarding Prasugrel is false? It's third-generation thiodopyridine. It has more potent, consistent, and rapid inhibition of P2Y12 receptor. In a pre-specified subgroup analysis, treatment with Prasugrel seemed to be less effective in subjects with diabetes compared to clopidogrel. It does not seem to be prone to alterations in pharmacokinetics, pharmacodynamics, or clinical efficacy on basis of genotype. And in the TIMI-38 trial as a whole, those patients greater than 75, age less than 60 kilograms over the prior TEA benefited more from clopidogrel versus Prasugrel. So which one's false? Someone said B. Yeah, exactly. All the other ones are true. And in particular, when it comes to that trial, you guys know this in clinical practice, you don't want to give Prasugrel to somebody over the age 75, less than 60 kilogram body weight or prior TEA or stroke. So in the subgroup analysis, Prasugrel actually had a more amplified effect in the diabetic cohort substudy. When you looked at the primary endpoint of subgroup analysis, those with diabetes had a greater splay of curves versus those without diabetes. And this was also shown true in Ticagrelor as well. Okay, number 7, in the platelet inhibition and patient outcomes, otherwise known as PLATO, testing for Ticagrelor as compared with clopidogrel among patients with ACS, how did Ticagrelor affect the rates of mortality and non-cabbage major bleeding? These are the two things that we teach our fellows here that are so important with this trial. Someone said B? Excellent. Very good. So Ticagrelor in the PLATO trial showed a reduction in the primary endpoint, the death, MI, and stroke. Very, very important. And more importantly, the primary safety endpoint was major bleeding. And there was a higher risk of non-cabbage major bleeding in patients randomized to Ticagrelor. In addition, the higher rate of dyspnea compared to clopidogrel. So there is bleeding with it, it's just non-cabbage related. Okay, number 8. So a 75-year-old female with diabetes, hypertension, high cholesterol, smoker, and PAD, undergoing she has a history of non-ischemic cardiomyopathy with a low EF of 30%. She came with acute chest pain, positive troponin, diagnosed with an ACS. EKG showed new onset AFib at 95 with nonspecific changes. Her pertinent labs are hemoglobin of 9, platelet count 235, creatinine of 2. She's taken to the cath lab, has a critical 95% proximal LAD, and underwent a PCI with a current generation DES. So what is the optimal antiplatelet regimen after PCI for this patient? So aspirin 81 milligrams daily, clopidogrel 75 daily, and apixaban 5 milligrams BID for 12 months. Aspirin 81 milligrams daily, for 4 weeks, clopidogrel 75 milligrams daily, and apixaban 5 milligrams for 12 months. Aspirin 81 milligrams daily, Plavix 75, warfarin INR goal 2 to 3, or clopidogrel 75 milligrams daily, and apixaban 5 milligrams BID for 6 months. Yeah, you guys got it. So whoever said D. So I will take B as well. Okay? I realized this the other day when I was looking at these. So B is a correct answer as well. It's not wrong to do it for a continuation of 12 months, and if they bleed, you can scale back. And I see why you chose that, because she's an ACS patient. And we showed in the guidelines we really want to give these patients a year antiplatelet therapy. But you can get away also with a 6-month duration if you feel like the patient's very high bleeding risk. And how do we define it in this patient? Well, she's aged greater than 75. She's got renal disease. She's anemic, and she's on not NSAIDs, but oral anticoagulants. That has to be shifted over. So she's got 4 of the criteria. She's going to be a high bleeding risk. So I would take 6 months or 12 months of a P2Y12 receptor antagonist. And there was a consensus statement in 2018. I really like this graph. Dominic Angelillo did this back then with a consensus. So your default strategy is on the left. So low risk, low bleeding risk, you're going to do triple therapy, periprocedural, meaning aspirin, clopidogrel, and anticoagulant. And then you're going to continue it up to 12 months with a DOAC and a P2Y12 receptor. So warfarin is gone. Everybody knows that for these types of patients. If you have a high bleeding risk or a high ischemic risk, which you could argue is this patient, she had a non-stemic, and a low bleeding risk, not really this patient because she's higher bleeding risk, but in the higher thrombotic patients, you can do up to 1 month of DAPT, and then you'll continue clopidogrel and DOAC. With your higher bleeding risk, low ischemic risk, you're going to do just 6 months. So I think she's in between here because she's actually high bleeding risk and high ischemic risk. She's both. So it's pick your poison kind of thing. I probably would have done a 12-month knowing myself and watched her very closely with the comfort that we can pull back if we need. The guidelines that I showed you are actually now out and address this, that patients with AFib undergoing PCI and taking oral anticoagulants, so not like this patient, it's recommended to stop aspirin after 1 to 4 weeks and continue the P2Y12 in addition to a DOAC. And you guys know the DOACs, rivaroxaban, dabigatran, apixaban, and endoxaban. Okay, number 9. So 76-year-old with chest pain and abnormal stress tests. She stented in mid-LAD with a drug-eluting stent. 1 week after the stent, she had shortness of breath. You concluded this is a result of a well-documented side effect of Ticagrelor, which we talked about, and discussed options for antiplatelet de-escalation therapy. Which regimen is the most appropriate for this patient? So she's on Ticagrelor and aspirin at this time, 1 week after her DES for stable ischemic heart disease. So you're going to stop Ticagrelor, start clopidogrel 75 once daily, 12 hours after the dose. Stop Ticagrelor, start 300 clopidogrel 12 hours after the last dose. Stop Ticagrelor, start 600 clopidogrel 12 hours after the last dose. Stop Ticagrelor, start clopidogrel 75 24 hours after the last dose. C, great job, guys. That's exactly right. So you all know this. You can't just start clopidogrel 75, you have to load. Different mechanism, the P2Y12 receptor is going to be open and ready to activate. Ticagrelor does not act on the P2Y12 receptor. It's an allosteric inhibitor of it, so your receptor will be ready to activate if need. So you need to load it. This is the form, this was a SWAP 4 trial that showed that basically the curve in red versus the curve in green. The curve in red is 600 milligrams. 600 milligrams of clopidogrel right here. Look at 24 hours. So your orange curve is Ticagrelor. You can see your platelet reactivity is in the basement, which is great. But 24 hours after, with a 600 milligram load, your platelet reactivity is significantly less than a 75 milligram or a 12-hour load. So that's why we like to do 600 milligrams 24 hours after the last. Or you can do 12 hours too. I usually tell patients, stop the Ticagrelor, take the Ticagrelor at night, your last dose, start the clopidogrel load at 600 milligrams in the morning. Okay, number 10. So this now 66-year-old with chest pain, abnormal stress tests. She's underwent a stent to the mid-LAD with a DES, started on aspirin and Prasugrel, 10 milligrams, Q day, not MD. 2 months after PCI, she developed bleeding, epistaxis. Which de-escalation regimen is the most appropriate in this patient? So now you have Prasugrel to clopidogrel. 2 months after the DES. Stop Prasugrel, start clopidogrel 75. Stop Prasugrel, start 300 clopidogrel. Stop Prasugrel, start 600 clopidogrel. Stop Prasugrel, start clopidogrel 75 once daily, 25 after the left dose. D. So clopidogrel and Prasugrel are both P2Y12 receptors. That receptor is going to be inhibited. This, if you're going to take a picture of anything, this is the thing to take pictures of. Not only so good, I doubt it may or may not be on the boards, but this is so clinically relevant and so easy to refer. This was a consensus statement put out a few years back, but it takes every scenario. You have acute phase, late phase, transitioning to each or other, depending on where you are. So in this patient, we're going from Prasugrel at a late phase beyond a month to clopidogrel. So you're going to take clopidogrel 75 milligrams daily, maintenance dose, that's what MD stands for, 24 hours after the last Prasugrel dose. So it's really neat, really convenient graphic. We give it to our fellows here in our cath lab manual, a great reference. Okay, which of the following statements is false regarding treatment of unstable angina or acute coronary syndrome? The proportions of ACS patients worldwide who are managed medically without revasc is 40 to 60%. Early invasive strategy is indicated in initially stabilized ACS patients who have an elevated risk for clinical events. In ACS patients treated conservatively compared to clopidogrel, Prasugrel significantly reduced the frequency of death from cardiovascular causes, MI or stroke. So false. Which one's false? C, yeah. Good job, you guys know this. So this was a trilogy ACS. Primary endpoints were null, but there was a higher bleeding risk in those patients that were managed with an ACS conservatively with Prasugrel. That's not the agent you want to use. You want to use that agent only if they're going to the cath lab and getting a PCI. I think this is the last question, and then you guys get lunch. So Champion Phoenix, IV ADP receptor blockade with Cangrelor had the following effect on stent thrombosis and severe bleeding, respectively, compared to clopidogrel. So, stent thrombosis and bleeding. D. D. So, Cangrelor is the IV analog, P2Y12 receptor, quick on, quick off. Very niche drug. Most of you probably have it, used preferentially in patients with an MI that have reduced absorption. But the nice thing about it has a plasma half-life of about 5 minutes. It's important to understand there are drug-drug interactions when you resume oral antiplatelet therapy with Cangrelor. If you're going to go back to a P2Y12 receptor, you have to stop the Cangrelor before you load it. If you go to a drug like Ticagrelor, you can just give it. You don't have to worry about the drug-drug interactions. Oh, this is the last one. All right. You receive a call from a physician in the ER who recently heard about a new medication called Ticagrelor. Not so new. And wonders how this drug is administered, as well as its antiplatelet effect and mechanism. Which of the following best describes the administration and activity of Ticagrelor? B. It's oral, it's reversible, it's a direct-acting P2Y12 receptor antagonist. It works just on the allosteric site of the P2Y12. So, but reversible, that's the key thing. That's it. I promise you, you guys will do okay.